Hi, my name is Amy and I'm the founder of Healthy Hoo Ha. Welcome to the third episode on the Female Desire, Arousal, and Orgasm series. This episode is on orgasm, as you can see by the outline I have here on the screen. If you haven't had a chance to check out the other two videos in this series, make sure you check those out as well, as the episode 1 is on general information and desire. The second episode is on arousal, and we'll get right into orgasm. So orgasm is defined as a defining moment of euphoria, ecstasy, and pleasure in which sympathetic systems move blood out of the genitals. It's a brief episode of physical release from the vasocongestive and myotonic increment development in response to sexual stimuli. So basically the culmination of everything that's been happening during arousal, the cresting of all the myotonic muscle tension, and the release of all the vasocongestion that's been happening. And as we will see later, it's the contractions of the uterus and the vaginal canal. I mentioned this in the first episode. I labeled it as shame around orgasms, but I didn't feel like that was a very good representation of what I was trying to get across. I wanted to talk about the hashtag orgasm gap. There is a big push the last few years to close the orgasm gap. Now, while I absolutely agree with this and think that women need to make sure that they are getting their fair share of pleasure from sexual encounters, but we also need to hold our partners accountable for being very selfish. I know a lot of times when we get into the heat of the moment and are very aroused ourselves, we can kind of sometimes forget about the other person's arousal and pleasure. And that's okay. We just need to be a little more aware and make sure that both parties, or all parties, depending on what you're doing, is getting what they should out of the experience. So the orgasm gap, for lack of a better term, shame put on the female for wanting to have an orgasm. Shame felt by many that don't experience an orgasm via penis in vagina sex. Females actually don't experience an orgasm via thrusting in the vagina alone. There needs to be clitoral stimulation of some kind, whether it's direct by using fingers or a toy additionally, or the partner rubbing their pubic area on the clitoral hood, the clitoris itself, things like that. So there are a lot of people that can't experience an orgasm, whether it's due to an orgasm disorder, hyposexual desire disorder, or HSDD, or any other vulvovaginal or sexual response issue that prevents orgasm. Yet these people still a lot of times can experience pleasure and fulfillment being intimate with their partner. They don't necessarily have to have an orgasm every single time. They don't have to have an orgasm at all. If there is somebody experiencing an orgasm issue, the intimacy and the arousal aspects are enough. There's also times where if you don't have an orgasm issue, that your orgasm just doesn't happen that specific time, and you're still fine having that intimacy and those arousal feelings, and the orgasm doesn't happen, and you're like, no big deal. I'm not going to put any pressure on that. So while I agree that we need to, close the orgasm gap, I think we need to not put so much importance on it. And as you can see here, I also put that the absence of full orgasm in a woman without distress does not always prevent the pleasure of sexual activity. Our orgasms can be really tricky. It's not any more fun for us when it's tricky as it is for our partners. So, we do what we can. And I think a lot of times we put a lot of pressure on having them. There needs to be no pressure. If you're finding that you're not having them often and you're having a lot of trouble, then yeah, go see a sexual health specialist. But once in a while, I think we're putting a lot of pressure on ourselves to have an orgasm constantly just because we're experiencing a sexual encounter. We could have so much more fulfilling experiences if we didn't worry about that end orgasm so much. Here's a topic that's debated a lot: is, are clitoral and vaginal orgasms truly separate anatomical and physiological entities? There's a lot of people who report that there's different orgasmic sensations when they're having direct clitoral hood stimulation, when they're having G-spot specific stimulation, when there's cervical stimulation, and when there's clitoral bulb stimulation. And I will pull up here. So I want to talk about the clitoris's anatomy and its role in the female orgasm, and the ability to orgasm during the penis in vagina sex directly correlates to the location of the clitoral anatomy in relation to the vaginal canal. So if you see here, obviously the vulva, and you can see where the vagina is, the urethra, and up at the top is the clitoris and the hood that covers it. And on the right-hand side of this diagram, you'll see the clitoris again, and the two legs that come off of it. That is the corpus cavernosum. And if you watched the episode 2 on arousal, you'll know that that is where the blood fills into. That has legs on both sides. But then there's this bulb. There's the bulb of the vestibule. So when the corpus cavernosum fills with blood, it puts pressure on the bulb of the vestibule. That also fills with blood via vasodilation. And so all of that is putting pressure, inward pressure on the vagina itself. And then when there's something in the vagina, that's putting outward pressure on those structures. So everything is really close together and getting all this pressure put on each other, which then stimulates that corpus cavernosum, and there's nerves along those two legs. And so those nerves are getting stimulated, which also goes up to the clitoris itself. So all of those nerves are getting stimulated. So this is how the clitoris plays a role in vaginal orgasms. When there's something in the vagina that's putting outward pressure on these structures, all the blood filling into the corpus cavernosum and the bulb of vestibule is putting inward pressure on the vagina. And so everything's getting super stimulated by being so squished together and being in close contact with each other. When we look up here at the different orgasmic sensations when having direct clitoral hood stimulation, G-spot, cervical, and clitoral bulb stimulation, that correlates to, so when somebody says that they're having a clitoris activated where there's direct stimulation to the clitoris or the clitoral hood itself, and in no other stimulation happening in any other parts of the genitals, that orgasm is characterized as a more localized and surface-based feeling for the woman than the vaginally activated. You'll see the vaginally activated one is described more as a deeper and more whole body. There's more parts involved with the vaginally activated orgasm. You have that the bulb of the vestibule, the two legs of the clitoris where that corpus cavernosum comes down. You have the orgasm platform that's getting direct stimulation. The G-spot is getting some stimulation because when arousal happens, the G-spot, and this will be shown a little bit later as well, but the G-spot swells. Some women it swells more than others, but there is some swelling regardless of the person. And so the vaginally activated orgasm is described as deeper and more whole body because there's a lot more being stimulated and involved. Some women have what's called a cervical orgasm, and that's described as more abstract, seeing showers of stars. This is technically an orgasm that some women can have. It stimulates a specific set of nerves. If you see on the right-hand side where the brain stem is, you can see where different parts lead to different areas of the spine. And I get into this a little bit later when I kind of break things down some more. Nipple orgasms. This is a thing. There's two parts. So nipple orgasms itself are a thing where there are women who can have an orgasm that is felt in their genitals. There's actual contractions. It's an actual orgasm just by nipple stimulation alone. And then most women actually need stimulation to achieve orgasm. It's not required. Like, it's not as though if we don't have any nipple stimulation, we can never have an orgasm. But most women actually need nipple stimulation to achieve an orgasm. These women, while they have a high degree of myotonia and vasocongestion in the genitals, they need that little bit of oomph from the nipple stimulation to increase activation in the specific brain areas where orgasm happens. So during self-stimulation of the clitoris, vagina, or cervix, they all have different but overlapping regions of what's called the genital sensory cortex. So clitoral stimulation signals are transmitted via the pudendal nerve to the spinal cord and then to the brain. Vaginal stimuli, including deep vaginal stimulation of the cervix, are additionally transmitted via the pelvic nerve, pudendal nerve, and the hypogastric nerve. Deep vaginal cervical stimulation sends signals to the brain via the vagus nerve, thus not relying on the spinal cord. Vaginal, clitoral, and cervical regions of activation were differentiable, consistent with innervation by different afferent nerves and different behavioral correlates. This comes from the Journal of Sexual Medicine. Nipple stimulation, why that can create its own orgasm and why it helps with regular orgasm abilities, is because the nipple stimulation also activates the paracentral lobule, overlapping with regions activated by genital self-stimulation. So I have a diagram for this. So as you can see, the clitoral signals at the bottom of the diagram here are transmitted via the pudendal nerve. That's way down at the bottom of your spinal cord. And then the vaginal stimuli, including the deep vaginal stimulation of the cervix, are additionally transmitted, as I said, via the pelvic nerve, as you can see there a little bit higher up, the pudendal nerve at the very bottom, and the hypogastric nerve. Super deep vaginal and cervical stimulation, so right way up there at the cervix where the uterus is, that travels to the brain via the vagus nerve and bypasses the spinal cord altogether. So this is how we can be having the different sensations. Like you can see above where the clitoris activated is more locally feeling, the vaginally active is a more deep whole body, and the cervical is described as more abstract. Well, they're affecting different nerves. Activation of the sensory cortex by imagined genital stimulation. So this is imagined and tactile self-stimulation of the nipple and clitoris, each activated the paracentral lobule, the genital region of the primary sensory cortex. So there's a part of your brain that registers the stimulation to your genitals or the nipples, right? There's a certain part of the brain. And when that gets enough stimulation and there's enough arousal in the genital area and the peak of the muscle tension and myotonia and the vasoconstriction, that's when the orgasm happens, right? Well, all this is happening in that primary sensory cortex. and the secondary somatosensory cortex. So we've been able to see via MRI that the imagined stimulation of the clitoris and nipple resulted in greater activation of the frontal lobe, that should say lobe, and orbital frontal cortex compared to actual tactile self-stimulation of these two bodily regions. Tactile self-stimulation of the clitoris and nipple activated the cerebellum primary somatosensory cortex, the hand region, and the premotor cortex more than the imagined stimulation of these body regions. I know it's kind of a lot of sciencey jargon, but basically it's saying that imagined stimulation is stimulating more of, so you have the part of the brain where everything is being lit up, but there's also different parts of that area. And so imagined stimulation is lighting up one little part of that area. Actual stimulation is lighting up another part of that little area. Imagining dildo stimulation generated extensive brain activation in the genital sensory cortex, secondary somatosensory cortex, hippocampus, amygdala, insula, nucleus accumbens, and medial prefrontal cortex, whereas imagining speculum stimulation generated only minimal activation. So you can see where it's like activating the different parts of that area, but the general idea that I put this into the outline for is that imagining stimulation of the clitoris and nipple was lighting up the orgasmic part of the brain just as much as actual physical stimulation. So that was kind of cool. So what causes myotonia? That is the muscular contractions. So what causes the muscular contractions or their prevention? Because that muscular contraction is where that tension, that muscle tension gets built up, which is then where the orgasm elicits from, is that cresting of the muscle tension. So where does it come from? Increased vasocongestion in the pelvic muscles triggers the muscle spindle stretch reflex and therefore overcomes what's something called the gamma bias to produce the rhythmic contraction. These contractions serve to reduce the pressure that the excess fluid from the vasocongestion is creating, and these contractions continue until the spindle bias afferents to determine the resistance is back to the baseline. So the vasocongestion is building up all this tension. The muscles are building up tension. And they get to this crest, this build up, right? And then you get the crest. Once the crest happens, immediately the orgasm happens to bring everything back down to normal, right? Prevention of the orgasmic contractions. Any restriction that prevents arterial filling will prevent the vasocongestion. Vasoconstriction maintenance, trigger of the afferent response at the clitoris, and muscles that will not respond to slight stretch or not coordinate well to contract. So any kind of pelvic floor issues that you're having will definitely prevent the myotonia cresting and thus the orgasmic contractions. Any issues with vasocongestion will prevent the cresting of the myotonic muscle tension and then prevent the cresting. So basically the myotonia is one of the more mechanical aspects of the orgasm. It's the release of the muscle tension and the vasocongestion. In the arousal episode, I put kind of what is happening at each stage, at each phase, what is happening to the different parts of the female body. Things like what's happening to the nipples at each stage, what's happening to the clitoris at each stage, etc., things like that. So, but I left out orgasm, obviously, because I have a whole episode on orgasm. So at orgasm in women, involuntary external rectal and or urethral sphincter may occur, but not always. So some women's rectal sphincter flexes involuntarily, some don't. It's not, a thing either way. Heart rate, blood pressure, pupil diameter, and pain thresholds each approximately double in magnitude. So right there at the crest, the heart rate, the blood pressure, all these things are spiking. The paraventricular nucleus of the hypothalamus, so just a part of the brain that's involved with the orgasm, produce oxytocin and become activated during orgasm, releasing oxytocin into the bloodstream from the posterior pituitary gland. In response to this oxytocin, the uterus contracts vigorously, generating sensations that women claim intensify the pleasure of orgasm. So very simply put, the oxytocin being released is where the contractions are coming from. The orgasmic platform in the vagina spasms. So you can see here, there's a little label there, but it's orgasmic platform, which is basically the outer third of the vagina. That swells and reduces the diameter of the vagina to about a third or more, depending on, whose body it's attached to. And then when orgasm happens, that has rhythmic contractions. The pelvic floor has rhythmic contractions. Dopamine drops and prolactin and serotonin shoot up. Prolactin and serotonin act to inhibit sexual desire. Endorphins and endogenous opioids get released. Opioids are the reward chemical. Dopamine is the chemical that makes us seek the reward. Opioids are the reward. Women can also have spontaneous or premature orgasms. The mechanisms that go into achieving an orgasm essentially happen too quickly in the case of premature orgasm, but not a lot is currently known. There's not a lot that's been done on this, so I wasn't able to put a whole lot into here or explain a lot about what's going on there. In spontaneous orgasms, little is also known about the exact mechanism that causes these. However, there are a couple of conditions that are associated with its occurrence, mainly PGAD, and that's persistent genital arousal disorder. So I mentioned this in the arousal episode. Basically, the person is constantly aroused. And while that may sound kind of cool, it's not. Because you're constantly on the verge of orgasm almost every moment of the day. And sometimes it can be a little painful because it's the nerves that are causing this constant arousal, and overstimulation of those nerves constantly isn't always a good feeling. Another cause of spontaneous orgasm is wet dreams. These obviously most happen while you're sleeping. There's a drug that's commonly prescribed for Parkinson's disease, and that will cause spontaneous. It has some report of causing spontaneous orgasms. Cannabis has been reported to. Exercise, childbirth, the G-spot orgasm. So it's technically, the term is the clitourethrovaginal complex, was coined to identify a multifaceted morphofunctional area which, when properly stimulated during penetration, can induce vaginally activated orgasms in some women. Vaginally activated orgasm involved the pumping effect on the cobalt plexus, while the root of the clitoris is particularly stretched by the penis and compressed against the anterior vaginal wall, the pubic symphysis, and the urethra, while the surrounding exocrine glands and erectile tissue. The diagrams for those aren't the greatest, so we'll just use the vulva and clit anatomy one again here. So the cobalt plexus is essentially where the corpus cavernosum comes together at the clitoral glands. It's where the two legs come together. So right in here is where that cobalt plexus is. And so that gets stretched and stimulated. And so where that comes together, right in this area where there's the bulbs on the side over here, and then the urethra and the vagina. And so up in this area that's getting stretched, when there's something inside the vagina, and then you're putting stimulation on that swollen bulb and the G-spot in there. And so that's activating those cobalt nerves. The bulbs communicate with the body of the clitoris via the network of veins along that cobalt plexus. Squirting. I think by now people have recognize that squirting is real. There's a lot that people don't know about it, but it might not be coming from where you think it is. So the female prostate, which it was previously termed the Skene glands or periurethral glands, surrounds the urethra within the anterior vaginal wall. So if you look on the left of this diagram where it says the urethral opening, on both sides of that urethral opening is where the Skene glands ducts are. And then underneath those mucous membranes are the glands themselves. The glandular component of the female prostate consists predominantly of ductal structures that open independently into the urethra, while the secretory component is relatively less developed. The female prostate is considered the main source of prostate-specific antigen in the fluid emitted from the urethra, resulting from direct stimulation of the anterior vaginal wall. You'll again look at where the urethra opening is. On both sides of those is the Skene glands ducts, and so like I said, underneath the mucous membranes are those glands. There's a type of female prostate fluid in those glands. It's just a fluid, and that fluid goes into the female urethra, and so when squirting happens, a bigger portion of that fluid has then leaked into the urethra itself. But there's more to it. A 2014 study using ultrasound to determine the mechanism of how female ejaculation or squirting occurs. When with empty bladders, the females arouse themselves in the manner necessary to create a squirting orgasm. Okay, and here's what the study had said. In all participants, after voluntary urination, which was confirmed through bladder emptiness, after a variable time of sexual excitation, just before squirting, there showed noticeable bladder filling. And just after squirting, demonstrated that the bladder had been emptied again. And we know that the female prostate, or the Skene glands, are putting the female prostate fluid into the urethra, okay? But biochemical analysis, as you can see here, showed that what was in the squirting fluid was urea, creatine, uric acid, and the prostate fluid. So even though they emptied the bladders before squirting, before, the actual act of squirting, while they were working themselves up to having a squirting orgasm, the prostate fluid went into the urethra, and the body, just doing its natural thing, the kidneys filtered the blood, created urine. That urine went down into the bladder, and then when the squirting orgasm happened, the prostate fluid shoots out, but it's also mixed with whatever amount of urine was created and put into the bladder. So while squirting is real, it does contain both the female prostate fluid and urine components. If I broke somebody's heart or made them angry, I'm sorry, but that was the analysis of what came out of the participants. It's prostate fluid and urine components. So while the act of squirting is real, biochemical analysis showed that the composition was made up of prostate fluid, fructose, and whatever urine components the kidneys had transported to the bladder during the sexual stimulation. The amount of urine components will vary greatly from person to person, as well as episode to episode among an individual. So the amount of urine components is really going to be determined by how much the bladder has filled during the buildup to that squirting orgasm. Health conditions that can affect orgasm ability. Clitoral phimosis, where the clitoral hood has essentially fused itself shut due to various other, whether health or hygiene conditions. Scarring is another health condition that affects orgasm ability, and connective tissue restriction. There's obviously movement, the muscle tension, if the muscle tension is not able to perform correctly because of restrictions. And then there's pelvic floor muscular underactivity overactivity or incoordination. So basically any pelvic floor issues have the ability to affect your orgasm ability. Now we'll get into some of the orgasm disorders. One of the orgasm disorders is frequency orgasm, is a frequency disorder. So the orgasm occurs with decreased frequency or is absent. Treatment includes treating the underlying cause, if any, and possibly adding estrogen and or testosterone therapy. So this one's basically is just trying to figure out, is it a physical problem, is it a mental problem, and then treating accordingly. Another orgasm disorder is the intensity. Some orgasms occur with decreased intensity, which is typically called a muted orgasm. Some people may never know if they're having a muted orgasm, as they've always just had them this way. And if they're fine with things, then that's no big deal. Then there's people who have their normal orgasms, and then they're noticing that something isn't quite as strong, something's wrong, and they go in and they say, my orgasms aren't as strong anymore, what's going on? And if it's not due to an older age, then it's a matter of finding out what triggered it. Was it medication? Was it an injury? Was it a mental health stemming problem? Treatment typically includes estrogen or testosterone therapy or vibrators, because vibrators will stimulate a lot more vasocongestion and myotonia to the area. Another orgasm disorder or issue is timing, where the orgasm occurs too early with premature orgasm or too late, which is the delayed orgasm. Treatment will depend on the type and the cause. Another type is pleasure. So an orgasm occurs with absent or diminished pleasure. Treatments include hormone therapy, antidepressants, medical devices such as pumps or vibrators. This again can be medication induced or mental health induced or age, an older age thing, or if you're having hormone issues despite being young. Another orgasm issue is FOD, which is female orgasmic disorder, is when a female cannot obtain an orgasm or has trouble achieving orgasm despite being sexually excited. Treatments for female orgasmic disorder include hormones, oxytocin, PDE5 drugs such as sildenafil, and the other ED drugs are basically erectile dysfunction drugs. Antidepressants such as bupropion and philbanserin and whatever that third one is. I'm not even going to try to say what that medication is. But they are basically dopamine enhancers. There's mechanical devices, like I mentioned earlier, like pumps or vibrators. There are topical lubricants and vaginal moisturizers, depending on what your specific issue is, obviously. And then there's fractional CO2 treatment, which you can take the time on your own to Google if you'd like to see what that's about. Then there's something called the post-orgasmic illness syndrome. So peripheral and or central aversive symptoms that occur prior to, during, or following orgasm. There is disorientation, confusion, impaired judgment, decreased verbal memory, anxiety, agitation, insomnia, laughter, dysphoria, crying, depression, fatigue, seizures, muscle weakness, paralysis, headache, diarrhea, constipation, muscle ache, sneezing, abdominal pain, diaphoresis, chills, hot flashes, pruritus, facial, ear, foot pain, and genital pain. There's a lot of different things that can happen with the post-orgasmic illness syndrome. They're all going to be at varying degrees depending on the person, depending on the orgasm. Maybe some of these can happen sporadically. Typically, the post-orgasmic illness syndrome is diagnosed if it happens very frequently and for about 6 months. Treatments include adding histamine, depending on what specific symptom that you're having. The treatment will vary, of course. And so treatments will include antihistamines, benzodiazepines, SSRIs, CNS stimulants, raising the testosterone levels to normal ranges, not increasing them any higher than that. That's That's just a dangerous thing to be doing. HCG, non-steroidal anti-inflammatories, analgesics, hyposensitization therapy, but no single therapy has proven to be the therapy to consistently work in every person. As you can see, these are a lot of different symptoms you can be having. I mean, one's diarrhea and the other one's constipation. So obviously one treatment can't be the treatment to take care of all of this. A higher rate of female orgasmic disorders were associated with surgical menopause, hormonal imbalances, current depression or anxiety problems, arthritis, urinary incontinence, or SSRI use. Orgasmic disorders are not as significant as female arousal disorders, but they're not super uncommon either. So if you are having an issue, don't feel like you're alone at all. There are a shit ton of people who have orgasmic disorders for one reason or another. We are doing a lot of things to our bodies with a lot of different medications. We're having a lot more procedures done, and these cause us issues. So if you're having an arousal issue or an orgasmic issue, get help, man. Like, you don't have to live super miserable. We might not be able to fix it completely 100%, but there's a lot that can be done, and you can, have a fulfilling sex life. So make sure to get in to see somebody. Some pharmacological agents that are being tested in women. I'm not going to try to name all of these. I will just butcher a lot of the names. They're medication names. I'm not going to try to properly pronounce them all. But you can see here that there's a lot that are being tested. There is a few that are already on the market. Vulvovaginal, I believe, is already on the market. Testosterone is already being used for at least the desire disorder portion, but they also help relieve orgasmic issues. So you can see there's a lot of pharmacological agents that are being tested in women to help with desire, arousal, and orgasmic issues. Obviously, I'm not going to get into how each one of these works. Feel free to Google how they might work in orgasmic issues if you would like to. We talked earlier about what happens to the various body parts and systems once orgasm happens in the arousal episode as well as this one. But basically, once orgasm happens, everything returns to its normal resting state pretty quickly due to the quick reversal of the vasocongestion. Now, if you are pregnant or having a pelvic floor related issue, the vasocongestion may not reverse as quickly because the vascular structures aren't functioning as well as they could be, and so things stay a little more vasocongested, and you may feel what's termed as blue balls. So you can see that not only if the vasocongestion happens slowly, but if orgasm itself is unachieved, the pelvic area can remain vasocongested and take much longer time to return to the non-congested state, resulting in blue balls. Women can get blue balls just as men can. Women can become energized or want to snuggle and have a quick nap, just smelling your skin and all the oxytocin and pheromones that have been released. So we're not quite sure why a single woman on one occasion will become super energized after and be ready to just get up and do whatever. And then that same woman on a different orgasmic experience will want to just snuggle and nap and just breathe you in, and all the pheromones and things that are just flying around in the room and pumping off the skin, and just fall asleep in that. But those are two ways that we like to enjoy post-orgasm. And some women want to just start the whole thing all over again. They're highly aroused right away and they want to get right back into having another orgasm. And this is because we don't have a refractory period. We have the returning to normal, but we can right away go back to highly aroused. We can also not go all the way back down to baseline. Like, we can have that reversal of vasocongestion that only goes down so far, and then we can ramp right back up, which is how we can be very multi-orgasmic. However, many women find that starting the phases over again in a short time frame is unpleasant as their genitals are still very sensitive. You don't have to be somebody who has super strong orgasms for your genitals to be very sensitive. You could, like, there's no set structure here. If, you know, you can be a person who has whatever level of orgasm intensity and then have whatever level of genital sensitivity. So if, despite how badly you want your woman to be multi-orgasmic or have another one in a very short period of time, her genitals are very sensitive and she wants you to stop whatever you're doing after the orgasm. Stop. It's really sensitive, and if you keep going, it can start to actually hurt a little bit because those nerves are so overly stimulated. So if she tells you to stop and she's running away from you, it's probably because it's not feeling as great anymore. You should probably just give it a rest for a few minutes and then try again in a little bit. But that's all I have for the orgasm episode. It's not as long because everything basically just peaks and then returns to normal. So there wasn't as much to talk about as in the desire and orgasm, or the desire and arousal episode. But so yeah, so make sure you check out the other 2 episodes if you haven't already, the episode 1 and 2, and then make sure that you subscribe to the channel so that you are alerted to any other videos when I post them, because I'll be doing videos throughout the year on various other topics. And then make sure to check out the Healthy Hoo Ha website at healthyhooha.com for the articles that I write on other subjects, as well as I get just as in depth on various other topics there. And thanks for watching.